Human skeleton as a dry, static framework. In reality, it is a metabolically active, living organ. Every single day, your skeleton is undergoing a constant, dynamic cycle of cellular remodeling. This entire process relies on a strict biological equilibrium between two types of cells: osteoblasts, which actively build new bone tissue, and osteoclasts, which break down and clear away old bone. Women enter this process with an inherent disadvantage. On average, they possess smaller body frames and a lower peak bone mass than men. This means there is less structural margin available when a major biological pivot occurs, the onset of menopause. To understand why menopause affects the skeleton so heavily, we have to look at estrogen. Estrogen acts as the primary chemical protector of bone tissue. It actively regulates the lifespan and the daily activity of both the cells that build bone and the cells that remove it. This graph illustrates the exact moment of uncoupling. As menopause sets in and estrogen production drops off, that protective regulation vanishes. Without estrogen keeping them in check, the bone-removing osteoclasts aggressively outpace the builders. As the gap between bone destruction and formation widens, density falls. It crosses first into osteopenia, indicating a moderate reduction in bone mass. If the resorption continues unchecked, it plunges past a second threshold into osteoporosis, a state where the bone architecture becomes porous, brittle, and highly prone to fracturing. The clinical danger of this progression is its silence. Bone loss is entirely asymptomatic. Patients feel no pain and notice no changes until a sentinel event occurs, which is usually a sudden fracture in the wrist, hip, or spine from a minor fall. Natural hormonal decline creates a profound structural vulnerability on its own. However, for many women, a second aggressive internal threat is simultaneously targeting the joints, accelerating that skeletal decay. Rheumatoid arthritis, or RA, is frequently confused with osteoarthritis. Osteoarthritis is a degenerative condition caused by the mechanical wear and tear of cartilage over time. RA is entirely different. It is a systemic autoimmune disorder where the body's own immune system attacks the joint lining. This attack begins with a break in immune tolerance. Through a normal process called citrullination, certain proteins in the body are chemically modified. But in RA-prone individuals, the immune system suddenly misidentifies these modified proteins as foreign invaders and produces antibodies to destroy them. This sets off a massive hyperplastic response. The thin, protective synovial membrane that lubricates the joint swells, becomes highly vascularized, and mutates into an aggressive, invasive tissue known as a pannus. Clinically, RA typically presents symmetrically, attacking the small joints of the hands and feet on both sides of the body at the same time. Patients experience joint swelling that feels soft and warm to the touch, accompanied by profound morning stiffness that lasts well over an hour. The disease essentially turns the joints themselves into localized engines of chronic inflammation. And the biological byproducts of that inflammation do not stay confined to the hands and feet. Because of this, the presence of rheumatoid arthritis in women acts as a major independent risk factor for accelerated osteoporosis. The two conditions collide, creating a triad of accelerated bone destruction. The first mechanism of destruction relies on pro-inflammatory cytokines, specifically proteins like TNF-alpha. These cytokines escape the local joint pannus and enter the patient's systemic blood circulation. This flow diagram shows inflammatory cytokines traveling through the body, hyperstimulating bone-destroying osteoclasts system-wide. The second mechanism is iatrogenic. Corticosteroids used for severe RA pain suppress acute inflammation, but actively block bone-building osteoblasts and intestinal calcium absorption. The third mechanism is behavioral. The chronic pain and deep fatigue caused by RA naturally lead to a reduction in physical activity. Bones require the physical stress of mechanical loading to stimulate new formation. Without movement, the skeleton receives no signal to rebuild. Combine menopausal estrogen loss, systemic inflammatory cytokines, and medication-induced bone suppression, the result is a synergistic assault on the female skeleton. Intercepting this requires specialized, aggressive intervention. Because this damage progresses silently, relying on visible symptoms is a losing strategy. The first line of defense requires advanced diagnostic frameworks that can detect the degradation years before irreversible architectural damage is done. On the left side of this dashboard, DEXA scans calculate a precise T-score, quantifying exact bone mineral density loss. On the right, blood tests screen for anti-CCP antibodies, highly specific biomarkers that predict the onset of RA long before joint swell. Once identified, physicians deploy targeted pharmacological therapies. Modern anti-resorptive medications, like bisphosphonates and certain biologics, work by chemically inhibiting the osteoclasts, stopping further bone loss in its tracks. For severe degradation, specialists utilize anabolic agents. Rather than just stopping the loss, these drugs mimic natural hormones, like parathyroid hormone, to actively stimulate the osteoblasts, forcing the body to construct entirely new bone architecture. These precision pharmacological tools give modern rheumatologists and endocrinologists exact biological leverage. They allow doctors to shift a patient's trajectory away from steady cellular deterioration and toward active skeletal restoration. Medication alone cannot complete the job. Medical intervention must be paired with mechanical adaptation. Research shows that high-intensity resistance training is a non-negotiable component of recovering bone density. Heavy mechanical loading physically forces the skeletal structure to adapt and harden. But that physical stress only yields results if the patient is consuming an optimized foundational intake of calcium and vitamin D, which provide the raw materials needed for cellular rebuilding. Managing these intersecting treatments requires a deeply coordinated clinical ecosystem. Endocrinologists managing hormone levels, rheumatologists controlling autoimmune inflammation, and physical therapists guiding mechanical loading must all operate in sync. Leading medical centers are also implementing specialized fracture liaison programs. These secondary prevention models ensure that if a patient does suffer a break, they immediately receive coordinated diagnostic and therapeutic care to guarantee it is their last fracture. By integrating early biomarker diagnostics, highly targeted medications, and rigorous physical resistance training, women have the tools to rewrite their musculoskeletal future. The combination of these sciences interrupts the silent trajectory of disease, offering a path to lifelong structural vitality.